Hello everyone. Let me present you my topic, which is the management and diagnosis of menopausal changes and diseases in gynecology. I'm Márkó Unicsovics from the obstetric gynecology clinic of Semmelweis University. My supervisors are Szabolcs Verbíró, Levente Sár, and my SMS is Fanny Mesnerich. My vision is to increase the quality of life among menopausal patients throughout finding better options in the management of menopausal diseases. These are my two specific goals. In the first one, I'd like to compare non-hormonal therapies in genitourinary syndrome, and in the second one, I'd like to find the diagnostic accuracy of office endometrial sampling. Let's get to the first topic, which is investigating the effect of non-hormonal menopausal therapy in genitourinary syndrome among menopausal patients. This is going to be a meta-analysis and a systematic review. So about the menopause, it's the permanent cessation for more than a year of menstruation and ovulation due to ovarian failure of any background. Naturally, it occurs between the ages 40 to 58. And out of all the patients, 80% experience some kind of hormonal withdrawal symptoms, which can be either vasomotor symptoms, sleep disturbances, psychological problems, and genitourinary syndrome, aka urogenital problems and sexual dysfunction coming with vaginal atrophy, vaginal dryness, dyspareunia, incontinence, vaginal narrowing, recurrent UTIs or so. So for up to now, the gold standard therapy is vaginal topical estrogen administration, but there is a huge discontinuation. Why? Because there is a huge non-realistic fear of breast cancer, endometrial cancer, and thromboembolism. Therefore, there is a great demand for a non-hormonal way of therapeutics, which comes with a very low risk of cancer and thromboembolism. So our aim is to examine the effectivity of non-hormonal therapies on genitourinary syndrome. The clinical question: is non-hormonal therapy effective in improvement of genitourinary syndrome among menopausal patients? So we'd like to examine those menopausal patients that have genitourinary syndrome. We'd like to use the non-hormonal therapies against placebo or gold standard therapies. Our primary outcome is going to be the hard outcome, which comes with vaginal maturity index, maturity value, and vaginal pH. All other outcomes are soft outcomes, goes to the secondary outcome. So our hypothesis is that non-hormonal therapies is ineffective in improving genitourinary syndrome in menopausal patients, and the clinical implication, of course, is providing a wide spectrum of therapeutic options for these women. We conducted a search with the search key you see here, with the hits in the bracket. All in all, with 1,600 articles found after removal, the duplicates and the abstract selection. Now I'm working with a full text selection. So far I found 25 that I want to use, but probably there will be more. 60%. Let's get to the next topic, which is investigating the diagnostic accuracy of office endometrial sampling in uterine premalignancies and malignancies. This is, of course, going to be a systematic review and a meta-analysis. So about the endometrial carcinoma, it is the #1 genital tract malignancy among women, with 35% of all genital tract cancers, with a very, very good cumulative survival of 84% all in all. Why is it so good? Because the symptoms appear very early, and therefore it is diagnosed 90% is very early stages. So the diagnosis goes with, of course, anamnesis, bimanual examination, ultrasound, but in the end, the diagnosis is based on a histology. For up to now, we use dilatation and curettage or hysteroscopic sampling as a gold standard. But they are resource demanding, which means you need operation room, you need general anesthesia, you need instrumentation, there is a crew, and of course, there is a fear that there are comorbidities between these patients. They are elderly, and of course there is a postoperative pain. So therefore, we need something that is easier to perform, it is less resource demanding, cheaper, only one person can do it, no need for operation room or general anesthesia. So these are the office endometrial sampling. But there's a question, are they accurate enough? So our aim is to examine the accuracy of office endometrial sampling for the diagnosis of endometrial cancer. The clinical question is, what is the diagnostic accuracy of office endometrial sampling for endometrial premalignancies and malignancies? We like to examine those women with suspected endometrial premalignancies or malignancies. We'd like to examine office endometrial sampling, and the reference is going to be dilatation and curettage or hysteroscopic sampling, and the disease we'd like to care with is uterine premalignancies and malignancies. Our hypothesis is that office endometrial sampling is non-inferior to dilatation and curettage or hysteroscopic sampling in the diagnosis of endometrial premalignancies and malignancies. The clinical implication is, of course, there is an effective and less invasive diagnostic tool for endometrial cancer coming with office endometrial sampling. Here is our preliminary search key with the hits and brackets, more than 2,500 all in all findings. So as an overview, I'd like to submit my first project May next year and the second one July next year. Thank you for your attendance. Let me forward you the message of my tutor. There is no inoperable patient. It is just that you must learn the way to do it. Thank you very much.
Everyone, I'm Gabor Blesko, and then just out of curiosity, because I've never done one, is it easy to perform an endometrial sampling, and does that the technique affect the results?
Thank you for the question. There are several techniques, and just out of the topic, it comes that they are easy to perform, but the technique, I believe, that will have an impact of the all-in-all accuracy.
Congratulations on your presentation. I would like to ask you a question regarding the second topic. To the best of my knowledge, a significant proportion of the office sampling will result in uninterpretable result. I mean, the sample will be too small to withdraw a conclusion from that sample. Mm-hmm. Do you have data about this proportion in comparison with the DNC procedure? Actually, can it be a source of bias in your study?
Thank you for the question. Yeah. In most of the articles that I read, it is written how big was the percentage of non-interpretable histologic samples. So usually it is not divided into groups. What was the cause? So it is just written that somewhy they cannot perform the pathological staging of it. But let me get back to the first question. I believe that, to Gabor's question, I believe that with the technique you can elevate the amount of those endometrial samples that then can be interpretable.
Congratulations to your presentation. Just a technical question. During the ART programs, we regularly do endometrial samplings. And if I can suggest to use transabdominal ultrasound guidance, why I suggest you? Because if you use that, you can enhance the safety of the project to introduce the catheter into the uterine cavity, and you can enhance the accuracy of the sample taking as well. So I do suggest to try. Thank you.
Thank you very much for your comment.